Assalamu alaikum. On behalf of PSA Karachi, I welcome all of you in today's lecture series. Um, my name is Dr. Azhar Rahman. I'm working as a consultant anesthetist at Aga Khan University Hospital. So today, in today's lecture series, uh, the presenter is Dr. Muhammad Saad, who is a consultant anesthetist and senior registrar at Dow University of Health Sciences, Dr. Ruth Pao, Civil Hospital, Karachi. He will present a very important topic, not only from the clinical point of view, but also from the exam point of view. That is postpartum hemorrhage, WHO recommendation for assessment and treatment. I would like to invite Dr. Saad. Dr. Saad, if you are hearing me, you can start your presentation.
Assalamualaikum.
Meanwhile, I would like to make some announcement as well. At the end of the this session, a feedback form will be distributed. Not it would be shared to all the participants. You have to fill it if you want to have a certificate, e-certificate. And if you have any question, just write it in the chat box. We will take the question at the end of this session. And I will request all the participants to keep your microphone on the mute. Thank you. Dr. Saad, you may start now.
Assalamualaikum. Am I audible to everyone?
Yeah, you are audible.
And everybody is able to visualize the PowerPoint presentation on your screens?
Yes, we can see your presentation.
Okay, so Bismillahirrahmanirrahim. And I welcome you all for today's lecture. So the topic is postpartum hemorrhage. And I have tried to keep it as precise and as to the point as possible. And today we are going to discuss the WHO recommendations for assessment and treatment. So as we are all aware that major obstetric hemorrhage is the leading cause of maternal morbidity and mortality worldwide, but it is the most preventable cause of death in this population. So before we move any forward, I would just quickly like to go through some basic definitions that the major obstetric hemorrhage is basically divided into antepartum hemorrhage that occurs from 24th weeks of gestation, and antepartum hemorrhage is further classified into major and massive APH.
Please turn off your microphone. Unisa, Yusuf Ali, please, your microphone is on.
So the major antepartum hemorrhage is bleeding of up to 1000 ml with no signs of shock. And if we talk about the massive antepartum hemorrhage, it is defined as bleeding of more than 1000 ml or any volume with clinical signs of shock. Now, moving to the topic that is postpartum hemorrhage. Postpartum hemorrhage is further classified into primary and secondary types, as we all know. The primary PPH occurring within 24 hours after delivery, and the secondary PPH, which occurs after 24 hours up to 12 weeks after the delivery. So these were the basic definitions, and there is a definition by the American College of Obstetricians and Gynecologists that PPH is more than 1000 ml of blood loss within.
Sorry, Dr. Saad, you're still on your first slide.
Yeah.
Or is it okay? So you are still on your first slide.
Yes. Okay, I'll
that's fine.
move it forward after just quickly recapping this definition.
Okay, that's fine. Yeah.
Okay. So the ACU, according to ACUG, PPH is defined as more than 1000 ml of blood loss within 24 hours with or without signs of hypovolemia and regardless of the delivery method. So moving forward. There is problem with this PowerPoint. Let me sort this out. Okay, so postpartum hemorrhage remains the leading cause of maternal mortality worldwide, accounting for 27% of all maternal deaths, as we have already discussed. With an estimated 14 million women experiencing PPH each year, effective detection and management strategies are critical to reducing maternal mortality and achieving the Sustainable Development Goals. These evidence-based recommendations focus on two key interventions that can significantly improve outcomes for women experiencing PPH: objective measurement of blood loss and standardized treatment bundles. So our today's discussion will be revolving around these two major recommendations by WHO, that is measurement of blood loss and standardized treatment bundles. The following presentation outlined the WHO's latest guidelines for healthcare providers, policymakers, and maternal health stakeholders to implement these life-saving approaches in various healthcare settings. So the global burden of postpartum hemorrhage, as uh, defined by the stats that are provided by the WHO, there are 287,000 maternal deaths. This is in 2020, with 87% occurring in sub-Saharan Africa and South Asia. 27% deaths are due to hemorrhage, and where the obstetric hemorrhage is the leading cause of maternal mortality worldwide. There are 14 million of PPH cases annually. Postpartum hemorrhage, as we already discussed, is defined as blood loss of 500 ml or more within 24 hours after birth. Severe PPH is defined as blood loss of 1000 ml or more. The majority of these deaths are preventable with timely detection and appropriate management. And since these deaths are preventable, therefore these guidelines came into existence, focusing on the methods to quantify the blood loss and then treating it accordingly. So in March 2023, WHO convened the first global summit on postpartum hemorrhage to identify research, guideline implementation, and advocacy priorities needed to end preventable maternal deaths due to PPH between 2023 and 2030.
Yeah, now it's projecting.
Okay. So the key challenges in PPH management, according to WHO, include inaccurate assessment, inconsistent treatment, and resource limitations. Visual estimation of blood loss is frequently inaccurate, leading to delayed recognition of PPH when it's too late for life-saving interventions. So the current recommendations are for quantitative assessment of the blood loss, and it can be done by gravimetric or photometric means. Inconsistent treatment is the another key challenge in PPH management. There is lack of standardized approaches to PPH management, and it results in variable care quality and outcomes across different settings. Resource limitations: many facilities lack essential medicines, equipment, and trained personnel needed for effective PPH management. So these are the key challenges that we, as anesthetists, daily face while managing our obstetric patients undergoing PPH. The 2012 WHO recommendation stated there was insufficient evidence to recommend the measurement of blood loss over clinical estimation. New evidence from large-scale trials has prompted a re-evaluation of this position. So the new evidence is the E-motive trial. And in May 2023, the trial was conducted, and the E-motive trial, it involves 200,000 participants. And it showed that the results of the trial showed 60% reduction in the composite primary outcome of severe PPH, laparotomy for PPH, and maternal deaths from PPH. This large multi-center trial evaluated a complex intervention comprising objective detection of PPH using calibrated drapes, and number two, standardized treatment bundle for PPH management, and number three, implementation strategies to ensure consistent application. So these are the results of the E-motive trial that shows a significant reduction in mortality and morbidity when these WHO guidelines were implemented, where the basic were changed, and the the detection of the blood loss, instead of being clinical, it was objective, that is quantitative, and there was a standardized treatment bundle was used for the management, which was implemented in the majority of the obstetric setups and resulted in 60% reduction in the uh, primary PPH, as well as the surgical intervention required for the management of PPH. The significant results of this trial prompted WHO to review all available evidence on PPH detection and treatment bundles to update guidance for member states. So the WHO recommendations, the first recommendation is assessment of postpartum blood loss.
Sorry, Dr. Saad, we can't hear you. Are you there, Dr. Saad?
Yes, yes,
Are you there?
yes, I am there. I guess there is some problem with the internet. I'm extremely sorry for that. So the
Okay.
WHO recommendation, the first recommendation is regarding the assessment of postpartum blood loss. So the recommendation is that for all women giving birth, routine objective measurement of postpartum blood loss is recommended to improve the detection and prompt treatment of postpartum hemorrhage. Methods to objectively quantify blood loss, such as calibrated drapes for women having vaginal birth, can achieve this. So the entire focus is to from the shifted from the clinical assessment of blood loss to the quantification that is based on objective methods. To improve outcomes. Am I audible to you guys?
Yes, you are audible right now.
Okay. So while most evidence comes from the studies using calibrated drapes for vaginal births, the GDC noted that measurement of blood loss in women undergoing cesarean section is also clinically important. The process should respect women's customary or cultural requirements, including choice of birth position, and should include discussion of bleeding risk with women throughout the birth continuum. The next recommendation by the WHO is the treatment bundle, and it is recommended that a standardized and timely approach to the management of postpartum hemorrhage, comprising an objective assessment of blood loss and use of a treatment bundle supported by an implementation strategy, is recommended for all women having a vaginal birth. So they have suggested this treatment bundle: uh, uterine massage, rapid institution of uterine massage to stimulate contractions, then medications which includes administration of an oxytocic agent and tranexamic acid, IV fluids, prompt administration of IV fluids, thorough examination of the genital tract, and timely escalation of care where needed. All bundle interventions should ideally be initiated within the first 15 minutes after diagnosis of BPH. In the E-motive trial, the treatment bundle was initiated when measured blood loss was more than 500 ml or when measured blood loss was more than 300 ml with early warning signs of excessive blood loss. So now comes the question how to implement these recommendations. So they have suggested the strategies for the successful implementation of these major recommendations. Number one is audit and feedback, regular monitoring of PPS detection rates, bundle use, and health outcomes with feedback at monthly departmental meetings. Number two, designated midwife and doctor at each facility to oversee change, troubleshoot issues, and provide feedback. Number three, equipment readiness. PPH trolley or carry case regularly checked and restocked with all necessary medicines and devices. And number four, training programs on site, simulation based and peer assisted training supported by guides, flip charts, and job aids displayed in labor. The successful implementation of these recommendations require adequate staffing, high quality commodities, and appropriate training to maximize the opportunity to replicate the finding of the E-motive trial. Now, the health system requirements that are necessary for the implementation of these guidelines. So they have divided it into essential and system strengthening resources. Essential resources that would be necessary for the implementation of these recommendations by the WHO include calibrated blood collection drapes. Definitely, if these calibrated drapes are available, then the quantification of the blood loss can be done. Quality certified uterotonic medications. Uterotonic medications which we are commonly using like oxytocin, which is the first line therapy, or carbetocin, and then prostaglandins and ergot alkaloids, they are being given prophylactically to all the obstetric patients. Tranexamic acid with proper storage. So regarding the tranexamic acid, here I would like to mention about the woman trial, and it was conducted and showed that the bleeding was reduced by 20%, and when the tranexamic acid was given, and the highest success rate was when it is used within the 3 hours of childbirth. IV fluids and administration sets, definitely the goal is during resuscitation is restoration of blood volume and oxygen carrying capacity. PPH emergency kits and trolleys, adequate staffing levels, and training material and job aids. The factors that will make it easier for implementation of these recommendations or strengthening the system include updated clinical protocols and guidelines, robust procurement and supply chain systems, regular competency assessment for health workers, data management systems to monitor implementation, clear referral pathways for escalation of care, community engagement strategies, sustainable financing mechanisms. National, regional, and district level health systems must be strengthened to ensure sufficient resources are available for sustainable implementation. Special attention must be given to the correct dosage and safe use of uterotonics and tranexamic acid, with efforts to minimize risks of misuse or adverse interactions. While evidence largely comes from secondary level facilities, implementation in primary care settings, community facilities, and home birth is equally important with appropriate adaptation. So these guidelines are not only made for hospitals, but they can be followed at the small birthing units, and in the cases where the birthing is being done in the home. Now, these are the potential implementation barriers that has to be removed or minimized in order for the implementation of these recommendations and to reduce the morbidity and mortality that is associated with the postpartum hemorrhage. So human resources, lack of skilled personnel with necessary expertise to implement, supervise, and support recommended practices will definitely uh, enable the implementation of the recommendations. Supply chain inconsistent availability of essential equipment, supplies, and medicines needed for implementation. Information systems, which include lack of health information management systems to document and monitor recommended practices, and infrastructure that is inadequate facilities and basic infrastructure to support interventions, particularly in low resource settings. Addressing these barriers requires coordinated action between international agencies, national departments of health, and key maternal and perinatal health stakeholders. Implementation should be adapted to local context while maintaining the core principles of the recommendations. So up till now, we have discussed the recommendations and the potential barriers that can lead to the uh, increased morbidity and mortality in cases where the recommendations cannot be implemented. We have also discussed the factors that can help us in implementing these recommendations. So moving on to the future directions and the research priorities that will definitely help in the earliest implementation and of these recommendations and the further be done for the management of these patients.
जी
Uh,
सर और सर उसका
so the
लाल वाले केसेस के अभी तक वो आई नहीं सर
measurement methods identify the most accurate methods of objectively quantifying blood loss after childbirth, including for women experiencing cesarean section. So they haven't provided any universal method to quantify the blood loss, as it would be very difficult to apply the same strategy in the developed world and in the developing world. So what they have suggested is to use the local guidelines, but the focus is on the quantification of the blood loss instead of relying on the just only on the visual assessment. Community settings develop accurate approaches for postpartum blood loss quantification for women giving birth at home or in community settings. Cesarean births determine the most effective care bundle for women who experience PPH after cesarean section. Sustainability identify strategies necessary to sustain the use of PPH treatment bundles over time outside of a research context. So these were the recommendations by WHO for the assessment and treatment of the postpartum hemorrhage. They haven't provided any universal guideline and have been recommended for to implement these everywhere, but they have advised to follow these recommendations and designing the local guidelines which could be easily implemented in the system. So this was all from my side. Any questions are more than welcome. Or if anyone has any advice or would like to share their experiences or their practices in the management of PPH.
Thank you, Dr. Saad. Yes, if anyone has any question, they can unmute themselves and please ask the question, or you can write it in the chat box as well. So, Dr. Saad, from the anesthesia point of view, as an anesthetist, how we should make the assessment, and because there are so many other points that you have mentioned that are pertinent to the obstetrician. So, from the practical point of view, keeping in mind these guidelines, how an anesthetist should proceed.
Okay, so as they have mentioned that the basic what I got to understand after reading these guidelines is that the entire focus was on the quantitative assessment of the blood loss. I am working at a government sector, so we solely rely on the visual evaluation, visual estimation of the blood loss, and it is definitely not the most reliable method. So, in the guidelines, as they've recommended, that there are the drapes are available, which can provide quantitative evaluation. So I guess if we could use these drapes, and it would be easier to at least quantify the blood loss and
अच्छा
manage it
कोई
accordingly.
नहीं अच्छा
Ifra, could you please mute yourself? Yeah, thank you. Yes, please, Dr. Saad.
Secondly, the availability of the drug should be ensured, which we are using on regular basis, like the oxytocin and the other utrotonics, in case where oxytocin cannot be used, and the availability of tranexamic acid, as is evident by the women trial, that it has the promising results. So the availability of all these things would definitely help us. And then prevention is the key. Adequate measures and steps should be taken to prevent the postpartum hemorrhage. And if there is any risk factors, then the adequate preparation should be done pre-hand.
Thank you, Dr. Saad. So Dr. Tabish Hussain is here. Tabish, could you please unmute yourself and ask the question?
Sorry, doctor, I cannot hear you. Can you repeat the question, please?
No, you have mentioned here in the chat box, Dr. Tabish Hussain here. So I thought you have some question to ask. Do you have any question
No,
to ask?
it is fine. I have just joined the meeting. Actually, I'm working in the hospital, so I just joined the meeting. So it's
Okay,
just a
okay,
hi to
that's fine.
everyone. Yeah.
Okay, so
Thank you
a
very much.
question by Dr. Shahid Dar. Any pre-op assessment of patient at risk for PPH?
So it is a multidisciplinary approach. Definitely, obstetricians are the primary doctors who are seeing these patients. And being an anesthetist, yes, what we could do, if there are certain risk factors, then we could do the adequate preparation that we all do while managing these patients, ensuring the availability of large bore IV lines and taking into the account the our hospital blood bank and initiating the massive transfusion protocol, the use of the fluid warmers and the arrangement of post-op ICU and HDU care, and intraoperative use of adequate blood products, TAG and ROTEM. So these could be done to prevent the occurrence of the PPH itself.
Yes, thank you. So for the pre-op assessment, we can look at the vitals as well and other parameters as well. For example, we can check the peripheries. We can assess the degree of shock if the patient is in shock or the degree of hemorrhage. So we have to do the preparation according to our assessment, what we have assessed. And then we have to, if some resuscitation is required, we have to do resuscitation, and then we have to proceed for the surgery. But again, if this is an emergency case, we have to look all these things simultaneously. So there is another question by Yunus, Dr. Yunisa Yusuf. She want to know how do you
I would
use?
like
मैं इनको खत्म करके मैं देखो बैठ के कोई मसला होता है तो बच्ची से पूछ लेना
Hello. Yeah.
Yeah, regarding
Uh,
the preparation, I would like to add that there are bundles of Safe Motherhood Initiative. So,
yeah.
if anyone wanted to go in details regarding the pre-op preparation of such patients, I would highly recommend to go through these bundles, where they have described the screening protocols for these at-risk patients and optimization of these patients pre-op.
If you have any link of these guidelines, it would be very kind of you if you could share these
Yeah,
guidelines in the chat box.
by at the end of the presentation, I have mentioned the link.
Okay.
There is some problem with my internet connection. Apologies for it, but I can share the link in the message box. So
Okay.
these guidelines are available there.
Okay. So the
Dr.
question, yeah.
Sorry to interrupt you.
Who is-
This is Dr.
Yeah.
Ramesh. I have one question in my mind. Quickly, if you can answer, because regarding the postpartum hemorrhages, whenever the patients are coming to the theater, either they are elective or category 2 or category 3 cesarean sections, sometimes our nursing staff they are using the PPH scoring system. That that gives you the probability of bleeding during the surgery or after the surgery. So I'm not sure whether all the hospitals in Pakistan are using this, but I have find here in UK that it's very useful because based on the PPH scoring system, which is being communicated to the anesthetist by the obstetrics team, we are handling the IV lines accordingly. Sometimes we are doing cesarean sections with 18 gauge cannulas, but if the PPH score is very high, then we are putting wide bore IV cannulas. The blood bank is on standby. The whole theater team is on standby. The consultant is on floor usually. But if it's not, the PPH score is just below 4 or it's not anticipated bleeding, that we just go ahead with normal routine procedures. So I'm not sure whether we are practicing this in Pakistan or not, because I have been trained in Pakistan. I was working in Pakistan till 2020, and I never heard of this practice. So just any feedback or input from your side? Thank you very much.
Thank you, Dr. Abish, for your input. I have never used such scoring system, and I'm not aware if anybody is using. So, if anybody is using the system, kindly come forward and contribute.
Yeah. So there is another question regarding the use of transamine. Uh, how do you use transaminic acid particularly, and what is the maximum dose in 24 hours?
Okay, so the dose of tranexamic acid recommended by WHO is a 1 gram fixed dose given over 10 minutes, with a second dose if bleeding continues after 30 minutes. So these are the WHO recommendations for tranexamic acid, and as I mentioned before, that the results are promising if it is given within 3 hours of childbirth.
And what about the if we are giving it in a bolus form versus in a infusion form?
Uh, what they have advised is to give it in over 10 minutes, 1 gram over 10 minutes. So uh, we usually follow these practice, and
Okay. Okay, fine. So these are this point is mentioned in the guideline. Okay, so there is
yes.
a question by Dr. Maham. She wants to know how to prevent PPH in high risk patients.
Okay, so the prevention lies in the early detection. So it is a multidisciplinary approach. If the patients are at risk, these should be managed accordingly. And as we all know that the uterine atony is the most common cause of the PPH, and it accounts for approximately 80% of cases of primary PPH, and that's why it is recommended to give prophylactically uterotonic drugs to all the obstetric patients, not only those who are at risk. And secondly, the most common causes of the secondary PPH that is occurring after the 24 hours of the birth are endometriosis or retained product of conception. So these things should be carefully looked, and the risk should be removed.
Okay, thank you, Dr. Saad. So there is another question regarding the transfusion by Dr. Shahiddar. Transfusions, triggers, and any protocol for resuscitation.
Okay, so regarding the blood transfusion, as if we talk about the red cell transfusion, so it is done on the clinical grounds. We clinically assess for the anemia, or we can regularly check the hemoglobin levels, and then transfuse. There is no clear-cut hemoglobin level for the transfusion as per WHO recommendations or guidelines. Yet they do suggest the transfusion of RBCs based on the clinical uh, assessment of the patient. Regarding the platelets, transfusion trigger of 75 is recommended during hemorrhage. And regarding the plasma and fibrinogen, the coagulation target should be to maintain PT and APTT at less than 1.5 times normal, and fibrinogen 2 gram per liter is required to maintain hemostasis during hemorrhage. And this
Thank
is
you.
mentioned in the guideline as well as the these are the recommendations from the BJ.
Thank you. So another question by Dr. Tabish Hussain. Use of symptometrine, any role?
Okay.
Yeah, Dr. Saad, I just want to give an input. I think it will be very useful. Is that all right?
Yes, yes, please.
When I joined, I'm working in UK for the last 1 year. When I came here, especially in Northern Ireland, we were using this simple syntocinon or oxytocin 5 international units start dose at the once the baby is delivered, and that is, I think, acceptable everywhere. We are also practicing the same thing in Pakistan. I was doing the same thing, but recently, for the last 3 months, we have changed the practice. It is according to the NHS policy. They have changed the practice from simple oxytocin or syntocinon to symptomatrine. It's a pre-filled syringe. It comes having some quantity of ergometrine and some quantity, I think it's 5 units of oxytocin. And it's a combination. And we usually give it start dose after the delivery of the baby, and it has a very positive role. Um, and I think this practice is completely evidence based. I'm not sure whether it's available in Pakistan or not, but it is working very well, especially in the cases where we are anticipating a lot of bleeding in the postpartum phase. And I already gave you a feedback that I was not aware about the PPH risk scoring system. So they are following this PPH risk scoring system. I'm sure you will be able to find on the internet through the Google the PPH risk scoring system. Usually, the risk is calculated based on the number of factors present in the patients. Either she is a primary gravida or multiparous, or uh, she has previous history of bleeding or not. So there are multiple factors, and while considering all these multiple factors, they calculate a risk score. And usually, if the risk score is above 4, we consider those patients as uh, potential risk for bleeding in the postpartum phase. So while keeping these risk factors, we prepare, before the procedure, we inform and involve the blood bank. Like Dr. Saad very correctly mentioned, that it is a multidisciplinary team approach. So we inform and involve all the disciplines like the blood bank, the pathologist, and the neonatologist, the anesthesia consultant on floor, and definitely the obstetrician and their consultants in the backup for suspected bleeding and their management. And I think it is working very well because the incidence which I have found in Pakistan, the risk of PPH was very high, and it is very less. So far in 1 year, I have seen only just a case, single case, and they managed it very well. And the third input I would like to give regarding the transfusion threshold, or the point where you will think about activating either the massive hemorrhagic protocol or trigger for giving a stimulus to the blood bank to arrange the blood and the blood products, is 1500 mLs. For a normal healthy patient, if she's having a hemoglobin above 11 grams and with the normal coagulation profile, because till 1 liter they are happy enough, and just the IV fluids and the colloids will work very well while maintaining the hemodynamics. But I think after 1500 ml, we this is the trust policy in my hospital, that after 1500 mLs of bleeding in any cesarean section, we have to inform and involve our consultant and the registrar from the gynae. They have to inform and involve their consultant, and we have to ring the blood bank and put them on the standby. So it's just a small feedback. I think it will be very helpful for all the doctors who are practicing over there. Thank you very much.
Thank you, Dr. Tabish. Okay, so there's another question regarding the external abdominal aortic compression. Is there any role of external abdominal aortic compression? And another question related to this is external abdominal aortic compression or internal iliac artery ligation, which one is more effective?
Okay, so these all are the interventions to control hemorrhage besides the pharmacologic management. So bimanual uterine compression is recommended. Intrauterine balloon catheters are effective in more than 95% of cases. Besides this, hemostatic compression sutures that are most commonly used at cesarean section So ligation of uterine and utero-ovarian arteries can reduce uterine bleeding. Cross-clamping of aorta can be used as a temporizing measure in cases of massive hemorrhage, and the use of the REBOA, that is resuscitative endovascular balloon occlusion, and selective radiological embolization of the uterine artery can be done. So these are the interventions to control hemorrhage. The question that which one is effective, so I haven't found any benefit of external abdominal aortic compression, but yes, internal iliac artery ligation is documented in literature and is effective. So definitely it will be more effective. Secondly, the peripartum hysterectomy is the definitive last resort. And as per the recommendations, it should be resorted to sooner rather than later, especially in cases of accreta or uterine rupture. I hope to answer the question.
Thank you, Dr. Saad. There is another question regarding the use of oxytocin. Can we repeat oxytocin 5 units? If yes, when to repeat? I mean, after how long?
So the recommended dose for the of oxytocin for PPH is, as already Dr. Tabesh discussed, that after vaginal delivery, 5 IU is given IV slowly, and then you can use the infusion at 2.5 to 7.5 international units per hour, and if required, after 2 minutes after the initial bolus, give a further dose of 3 international units over 30 seconds or more. So you cannot, as per these guidelines, 5 international units cannot be repeated, but you can give 3 international units as a bolus dose within 30 seconds, 2 minutes after the first dose.
Okay, thank you. So there is another question by Dr. Khalid Rashid regarding the use of loop diuretics in case of hemorrhage and massive transfusion. So I think there is no strong recommendation to use the loop diuretics if you're doing the multiple blood transfusions to prevent any pulmonary edema as such. So if you have any recommendation regarding this, Dr. Saad, you can answer it.
No, I haven't read any recommendations regarding loop diuretics in the treatment of PPH, so I won't comment on this. And what you have mentioned is, I guess, agreeable for all of us, that there are no strong evidence for their use.
Thank you. Another question by Dr. Ambar Fayaz. What specific pre-op labs to order besides baseline tests in patients at high risk for PPH?
So I didn't find any specific tree of labs. They have mentioned regarding the screening for anemia and optimization of hemoglobin in the antenatal period to prevent any unnecessary blood transfusion. And besides this, I didn't find any specific lab in the general population.
Thank you. I'm sure all the questions are well answered. You all are well satisfied with the answers. So with this, I can't see any other question. A link of the feedback form has been shared. You can fill it to get the e-certificate. I would like to thank Dr. Saad for giving us the insight regarding the PPH and its management. Thank you. With this, we come to the end of today's session. We'll meet you after 2 weeks in the same lecture series. Thank you. Thanks, everyone.
Thank you, Dr. Azhar. Thank you, everyone.